This is a video in clinical medicine from the New England Journal of Medicine.
Focused cardiac ultrasonography is a practical, qualitative, or semi-quantitative means of assessing cardiac size, structure, and function that is performed and interpreted by the clinician at the bedside. Although the left ventricle has historically been the focus of echocardiographic assessment, the right ventricle is increasingly being recognized as having equal importance in the assessment of acute and chronic cardiovascular and pulmonary diseases. This video presents a practical method for conducting visual, semi-quantitative assessment of right ventricular size and systolic function with focused cardiac ultrasonography. Focused cardiac ultrasonography for right ventricular size and systolic function is indicated in patients with chest pain, dyspnea, arterial hypotension, unexplained tachycardia, hypoxemia, shock, acute respiratory failure, or cardiac arrest. Focused cardiac ultrasonography should not replace physical examination and often prompts the use of more advanced methods of evaluation, such as comprehensive echocardiography. The right ventricle, the most anterior cardiac chamber, is located immediately beneath the sternum. Its walls are thinner than those of the left ventricle, with abundant trabeculae projecting from the inner surface. The right ventricular cavity is enclosed by the endocardial border. On its coronal view, it has a triangular shape. On its short axis, it has the shape of a crescent as it wraps around the left ventricle. The right ventricle is a low-pressure, high-volume system that can expand and contract to accommodate changes in blood volume. As a result, right ventricular systolic function depends heavily on preload conditions and is remarkably susceptible to sudden increases in afterload. Systolic function relies primarily on shortening of the muscle fibers along the longitudinal plane, and secondarily on the radial thickening of the myocardium. Focused cardiac ultrasonography requires an ultrasound system with two-dimensional imaging, a phase-arrayed probe, ultrasound transmission gel, and a pair of gloves. Before beginning the procedure, wash or sanitize your hands. Explain the procedure to the patient and mention that the procedure is not associated with risks or complications. Put on a pair of gloves and expose the patient's thorax. Although imaging is optimally performed with the patient in the left lateral decubitus position, in many ill patients the only option is the supine imaging position. The remainder of the video will demonstrate the patient in the supine position. The recommended echocardiographic views for the visual assessment of right ventricular size and systolic function are the standard apical four-chamber view, the apical four-chamber view with focus on the right ventricle, also referred to as the right ventricle focus apical four-chamber view, the parasternal short axis view at the mid-papillary level, and the subcostal four-chamber view. To obtain any of these echocardiographic views, set the field depth to 20 centimeters, and then adjust the depth and gain to demonstrate structures of interest at their maximum size. To obtain an image in the standard apical four-chamber view, place the probe over the point of maximal impulse. Hold the probe at an angle of 60 degrees relative to the chest wall, facing the sternal notch, with the orientation marker pointing toward the 3 o'clock position. Optimize the image to see all four chambers of the heart: the left atrium, left ventricle, right atrium, and right ventricle. To obtain an image in the apical four-chamber view with focus on the right ventricle, first find the standard apical four-chamber view. Then, keeping the left ventricle in the center of the image, rotate the probe counterclockwise to demonstrate the maximal size of the right ventricular cavity on the image. To obtain an image in the parasternal short axis view at the mid-papillary level, place the probe over the third to fourth intercostal space to the left side of the sternum. Hold the probe perpendicular to the chest wall or tilt it slightly toward the apex. The orientation marker should be pointing toward the 2 o'clock position or the patient's left shoulder. The papillary muscles of the left ventricle and the interventricular septum should be visible throughout the cardiac cycle. The subcostal four-chamber view should be routinely obtained. It is best performed with the patient in the supine position, with their knees bent to help relax the rectus abdominis muscles. This view is described in the supplementary appendix to this video. To evaluate right ventricular size and systolic function by means of focused cardiac ultrasonography, use the following measures: cavity size of the right ventricle relative to that of the left ventricle, and shape of the interventricular septum, which are measures of right ventricular loading, as well as longitudinal shortening, also known as TAPSE, which stands for tricuspid annular plane systolic excursion, and change in the area of the cavity, which are measures of contractility. Cavity size of the right ventricle relative to that of the left ventricle is evaluated in the standard apical 4-chamber view. In each ventricle, the space enclosed by the endocardial border represents the area of the cavity. The diameter at the base of the cavity, measured immediately above the horizontal plane of the tricuspid annulus, can be used as a surrogate measurement in cases where complete visualization of the right ventricular cavity is not possible, and when the left ventricular cavity is enlarged or unusually small. Measure each ventricular cavity at end diastole, when the cavity reaches its maximum size. In addition, identify the apex of the heart and assess whether it is formed mainly by the left ventricle or the right ventricle. When the size of the right ventricular cavity is less than or equal to 2/3 the size of the left ventricular cavity, and the left ventricle forms the apex of the heart, then the right ventricular cavity size is normal, suggesting normal preload and afterload conditions. When the size of the right ventricular cavity is equal to or greater than the size of the left ventricular cavity, and the apex is formed by the right ventricle, then the right ventricular cavity is enlarged, indicating excessively increased loading conditions. The shape of the interventricular septum is evaluated in the parasternal short axis view at the mid-papillary level. When the shape of the interventricular septum is curved throughout the cardiac cycle, giving the left ventricular myocardium a circular shape, then right ventricular loading conditions are likely to be normal. When the interventricular septum becomes flat at times during the cardiac cycle, giving the left ventricular myocardium the shape of the letter D, then loading conditions are excessively increased. Longitudinal shortening is best evaluated in the standard apical 4-chamber view. Longitudinal shortening is the semi-quantitative version of TAPSE, a quantitative measure of advanced echocardiography. Identify the segment between the base and the apex of the right side of the heart, which corresponds to the right ventricular longitudinal plane. The lateral tricuspid annulus can be used as an anatomical reference point. The segment reaches its maximum length at end diastole. During systole, the segment shortens until it reaches its minimum length at end systole. The difference between the maximum length and the minimum length during the same cardiac cycle yields the estimated longitudinal shortening. A difference of at least 2 cm indicates normal right ventricular systolic function, whereas a difference of 1.5 cm or less suggests reduced function. Alternatively, in patients with normal left ventricular systolic function, right ventricular longitudinal shortening can be evaluated by means of comparison with left ventricular longitudinal shortening. When the longitudinal shortening of the right ventricle is at least twice that of the left ventricle, then right ventricular systolic function is normal. But when the longitudinal shortening of the right ventricle is equal to or less than that of the left ventricle, then function is likely to be reduced. Longitudinal shortening should also be evaluated in the apical 4-chamber view with focus on the right ventricle. Change in the area of the cavity is best evaluated in the apical 4-chamber view with focus on the right ventricle. The space enclosed by the endocardial border, excluding the papillary muscles and trabeculae, represents the area of the right ventricular cavity. The fractional decrease in the area of the cavity from end diastole to end systole during the same cardiac cycle yields the estimated change in the area of the cavity. A decrease of at least 1/3 suggests normal right ventricular systolic function, whereas a decrease of less than 1/3 suggests reduced function. The change in the area of the cavity should also be evaluated in the standard apical 4-chamber view. McConnell's sign is described as regional right ventricular dysfunction with decreased or absent motion of the mid-free wall, but normal motion of the apex. McConnell's sign is a specific finding that can help diagnose acute right ventricular systolic dysfunction, often in the setting of acute pulmonary embolism. However, McConnell's sign has a very low sensitivity, and its absence should not be used to rule out acute right ventricular systolic dysfunction or acute pulmonary embolism. To begin your evaluation of right ventricular systolic function, obtain images first in the standard apical 4-chamber view, then in the apical 4-chamber view with focus on the right ventricle, next in the parasternal short axis view at the mid-papillary level, and finally in the subcostal 4-chamber view. The subcostal 4-chamber view is described in the supplementary appendix to this video. This video shows images from two patients. Patient 1 has normal right ventricular systolic function, and patient 2 has severely reduced right ventricular systolic function. Both patients have normal left ventricular systolic function. In the standard apical 4-chamber view, identify the structures of interest, including the lateral tricuspid and mitral annuli, the apex, and the endocardial borders of the right and left ventricles. Evaluate the cavity size of the right ventricle relative to that of the left ventricle. In patient 1, the size of the right ventricular cavity is less than 2/3 the size of the left ventricular cavity, and the apex is formed by the left ventricle. In patient 2, the right ventricular cavity is larger than the left ventricular cavity, and the apex is formed by the right ventricle. Next, evaluate longitudinal shortening. In patient 1, longitudinal shortening of the right ventricle is at least 2 cm and at least twice the longitudinal shortening of the left ventricle. Whereas in patient 2, longitudinal shortening of the right ventricle is clearly less than 1.5 cm and less than that of the left ventricle. Finally, evaluate the change in the area of the cavity. In patient 1, the area is decreased by at least 1/3. Whereas in patient 2, the area is decreased by less than 1/3. Obtain an image in the apical 4-chamber view with focus on the right ventricle. The results for longitudinal shortening and for the change in the area of the cavity in this view are similar to the results in the standard apical 4-chamber view. In the parasternal short axis view at the mid-papillary level, identify the structures of interest, including the interventricular septum and the left ventricular myocardium. In patient 1, the interventricular septum is curved and the left ventricular myocardium has a circular shape throughout the cardiac cycle. Whereas in patient 2, the interventricular septum is flat and the left ventricular myocardium has a D shape throughout the cardiac cycle. As you perform the echocardiographic evaluation, it is essential to correlate and integrate the information collected in each view to complete the assessment of each measure. The results for the two right ventricular loading measures can suggest, but cannot confirm, a definitive grading of systolic function as either normal or severely reduced. If both loading measures are normal, as in patient 1, then right ventricular systolic function is likely to be adequate. In contrast, if at least one of the loading measures is abnormal, as in patient 2, then right ventricular systolic function is possibly reduced. The results for the two right ventricular contractility measures can confirm the grading of systolic function as either normal or severely reduced. If both contractility measures are normal, as in patient 1, then it is reasonable to grade the right ventricular systolic function as normal. In contrast, if both measures are abnormal, as in patient 2, then it is reasonable to grade the right ventricular systolic function as severely reduced, especially if there are concomitant abnormal loading conditions. Right ventricular size and systolic function must be interpreted with respect to the chronicity of the disease state. Patients with chronic right ventricular systolic dysfunction, which is characterized by thickening of the right ventricular free wall on advanced echocardiography and by abnormal loading conditions, can present with normal contractility measures. In contrast, patients with acute right ventricular systolic dysfunction present with abnormal contractility measures, frequently accompanied by abnormal loading conditions, regardless of their previous right ventricular systolic function. The use of focused cardiac ultrasonography for the assessment of right ventricular size and systolic function may be limited by the level of operator competence in obtaining images of the right ventricle, and by measure-related factors such as incorrect inclusion of trabeculae or papillary muscles in the measurement of cavity size, regional wall motion abnormalities, tricuspid valve disease or replacement, or concomitant enlargement of the left ventricle and reduced left ventricular systolic function. In patients with suspected or known cardiovascular or pulmonary disease, focused cardiac ultrasonography can be used to evaluate right ventricular size and systolic function on the basis of 4 measures: cavity size of the right ventricle relative to that of the left ventricle, shape of the interventricular septum, longitudinal shortening, and change in the area of the cavity.